So now we're going to talk about the muscarinic agonists, and then the indirect agonists include the cholinesterase inhibiting drugs. So for the first part, we'll just focus on the muscarinic agonist. And so muscarinic agonists basically are drugs that resemble acetylcholine, excuse me, and they have effector functions at this level. And so the drug binds to these muscles or these cells that express the muscarinic receptor, and they basically act like acetylcholine. And so all of these responses will occur with a non-specific muscarinic agonist. And so you can see changes in vision at the eye level. There are some blood vessel changes that will occur. Remember back in the CNS or in the cardiovascular respiratory unit, we had talked about norepinephrine binding to either beta 2 or alpha 1 receptors, causing either dilation or constriction. That still holds true at a kind of a smaller microvascular level. You can see some of this occurring, but the primary vascular response is really governed by norepinephrine and epinephrine through beta and alpha receptors. This is relatively nominal, but it does occur. From the lung, we see dramatic bronchoconstriction. And then, of course, in terms of glandular function, we see an increase in glandular secretion. This is very profound. And then, of course, there's a profound GI effect as well, and a profound cardiovascular effect, countering the effects of norepinephrine on beta 1, which we have already discussed. So of the direct-acting agonists, you can subcategorize them based on the chemistry. I don't really think it's important to know these two because there's only one alkaloid direct-acting agonist, and that's pilocarpine, and we'd just much rather you know what pilocarpine is. The cholinesters, acetylcholine can be artificially made, but its half-life is actually quite short, and I'll show what that looks like in a minute. Bethanechol and so forth, and muscarine are, of course, the kind of the older drugs. The indirect acting agonists include drugs that are listed here. We'll talk about those in the next video. We're going to focus on the direct acting muscarinic agonist. Carbachol, there's some debate as to, is it more nicotinic or more muscarinic? For this lecture, we're not going to worry about it anyway because it's for glaucoma. And in fact, most of these drugs are really for either glaucoma, xerostoma. This will treat GI atony, excuse me, post-surgically. Acetylcholine really is not made as a drug because its half-life is so short, because it's rapidly hydrolyzed by the next group of drug targets, the cholinesterases. And so there's very few drugs that act like really potent direct-acting muscarinic agonists outside of the first one, which was muscarine. And of course, the disease indication, of course, there are none. These are patients that take shrooms, and this is what happens to them. And so the major uses include the GI system, and all of those GI systems effects are more stimulatory. You can see, using these drugs for postoperative abdominal distension. And when you've got a reduction in motility, you can speed it up. You can use other drug classes too, listed here, to speed up motility. In terms of urinary bladder incontinence and so forth, and urinary bladder retention, these drugs kind of fit into that category, and of course in ophthalmology. So we're not really going to focus much on them, but what I do want to focus on is what happens when there's excess acetylcholine or excess muscarinic receptor agonist on board. And the best way to remember that is through this really cool acronym called SLUDGEM. And this kind of tells you at least, what the physiologic consequences to acetylcholine binding to these muscarinic receptors produces. And so, yeah, it's listed here at toxic levels, but even at therapeutic levels, you can see some of this occurring. Okay, so SLUDGEM stands for salivation, lacrimation, urination, defecation, GI upset, emesis, and meiosis. Okay, and whenever these muscarinic agonists are on board, or muscarine itself, or high doses of acetylcholine, you can see patients experiencing some or all of these symptoms. And we haven't gone through emesis per se, but the vomiting component is a specific region outside of the blood-brain barrier called the chemoreceptor trigger zone, sometimes called the BARF center. And this has a high amount of muscarinic receptor expression. And so when acetylcholine, of course, hits them, it produces emesis. Meiosis, you can see changes in the eye to produce accommodation. And of course, defecation, urination, lacrimation, and salivation we've already kind of talked about. So this is an important slide. You do need to know this, this process. This will help you tremendously throughout your career, because some of these patients may come in with some of these effects, and you'll have to know where it came from. So let's end this video here. The most important thing really is what is this? This is slide 39, the SLUDGEM acronym, and this relates to excess acetylcholine hitting muscarinic receptors and the resulting changes in physiology that occurs. Okay, so we'll stop here and we'll go into the indirect acting drugs in the next video.